I'm still involved in the work of the International Federation, where we do training in several projects in East Africa. And we see there that training is possible, but in most of the projects we need more help from professionals in the local hospitals, and the link between the the projects and the hospital is not always very well established. So we hope that we can find more inspiration here in a hospital like this, to have more people who are able to come for training and to be able to make the link with existing hospitals and with existing people in the hospital who are willing to help them when they have problems with the spina bifida population. What I try to tell you is that setting up a multidisciplinary team for working with spina bifida children, it's not simple. I started in '78 and it took time to 2005 before we had a real team. So you will recognize several pictures where you say, yeah, that we have here too. People working together, but working in a team together opens doors again for better care. So I said already that in the 70s they realized that we had a need for coordinated care. And when I started in '78, there was nothing. I started in the child neurology clinic with 35 patients with spina bifida. And I felt that they all got so many information from here and there, but they didn't know what to do with the information. So the article in the Lancet was about the necessity of the coordinated care of those children, but it took me time from '78 to 2005 to have it realized. My major goals for spina bifida care were to prevent the physiologic dysfunction to become disabilities and to prevent disabilities from becoming handicaps. For this, to achieve these goals, it requires a good coordinated care, and you need a team to give this care. But starting with a team was not simple. You have to have people with skills to work together, and they have to be able to work in a team together and to put the pieces of the puzzle together. In the beginning, it was the child with his parents and the team was several doctors, like we have here, the neurosurgeon, a pediatrician. We'll see the first members of the team. And then we had contact with the family doctor at home, who knew who we could send as a physiotherapist or nurse to help the people at home. So this was the first start of a kind of coordinated care. In the beginning, it was mainly a team of doctors, like you see here. I was a pediatrician, and as at that time pediatric neurology started, because it didn't exist in the 70s, I had two roles. We had a neurosurgeon, orthopedic surgeon. The urologists in the beginning, in very young children, they were seen by the pediatrician, and we went to the urologist when we thought that it was necessary, because the first time I went to urology to ask for urodynamics, he said, don't send them before they are 7, because they cry, and if they cry, I can't make conclusions. But it was a time that they didn't do urodynamics in small children in the 70s. So it was so new. They did do it in trauma patients, and they were adults, but not in children. So, but the team was mainly doctors, and they were not really working in a team together, but we tried to have once a week outpatient consultation like you have here, and it was a pediatrician, me, and an orthopedic surgeon together with the orthopedic people from the orthopedic workplace. What do you call it? Yeah, to make the appliances or to control the appliances. And the neurosurgeon was standby. It was meaning that we saw the children in the morning, and if we had problems, he was there at 3 o'clock. We had a meeting together with the neurosurgeon, also about other cases. But if we thought that there was a problem with one of the patients, they could stay until 3 o'clock and be seen by the neurosurgeon at that time. So not all the children were seen in every clinic only those who had a neurosurgical problem. The same with the social worker or the psychologist. They could come in when there was a need, like a child making the step to the primary school. We made an appointment to the psychologist to have the testing and so on, but it was not really sitting after that time together and discussing. They did the test and we got the results, but it was the beginning of a team. But if you work in a team, you have always to see that you work together up to the end, and those kinds of problems we have had several times. Spina Bifida Association in Belgium, the parents and the patients made an important contribution to the realization of the Convention of Spina Bifida with the Belgian government in May 2005. So it took more than 25 years before we had the real convention with the team. So the first team, I was very happy for the first time to have a real team nurse, and then we had a physiotherapist, a social worker, psychologist, an administrative team. So all those people were paid by money of the government. Each child with Spina Bifida coming to our clinic got a kind of envelope, and with the money of the envelope we had to pay those people. So I will explain a little bit more about this. But 8 years later we have the same team, and this was a very, very important issue, that the same team could go on taking care of the young adults and the adults. So the doctors would change, but the team, the Spina Bifida team, had to stay the same. So the nurse and the physiotherapist and the social worker and the psychologist are in the same team for adults and children, but the doctors will change from pediatricians to internal medicine. We were lucky that the neurosurgeon was starting with us in pediatrics, but going with the patients further on in adult care. So that was a good thing, because I think a lot of articles are written also because the problem of young neurosurgical patients growing up and going to other services later in life. So it was a local Spina Bifida Association who helped us to push the government to realize this convention. So, but you have to have a good national health system, and we knew already that it existed, the health system, the convention for diabetes, for epilepsy, for other chronic diseases. So that's why we insisted at the governments to have this convention also for Spina Bifida. And I read some articles about the insurance in America, where they saw at the emergency cases a lot of adults arriving with severe problems, and they calculated that if those patients had been seen in a regular follow-up, they wouldn't have so much problems. So the money spent in the emergency cases was compared with the money they would spend if there would be a regular follow-up. And this helps when you go for discussions with the government. Money is always an issue if you have to discuss. So the financial support from the National Health Service do 3 multidisciplinary centers in Belgium. They first said you have to have at least 100 patients in regular follow-up since 2 years. But I insisted that maybe they should take 50 for regular follow-up, and because otherwise we would have had only 2 centers in Belgium. And I think now it's Ghent and Leuven, and 1 in the French-speaking part of Belgium. And it was important then to train the team members of the multidisciplinary team to know more about Spina Bifida problems. Who has access to the convention? The children with Spina Bifida aperta and occulta. Occulta, when it was proven that there was a follow-up needed for tetrad cord symptoms, and also children with after spinal cord injuries, because they are not a good population to add to the spinal cord groups of adults, because it's happy to say that spinal cord injuries in children is rather rare, but they are not well adapted to be included in the adult spinal cord group. And for the adults from the transition from the pediatric care, but we insisted that also the adults we lost in the last 10 years, because they were too old to come to the pediatric hospital, could come to the convention again. And a lot of them came back after several years to be included in the Spina Bifida Convention in Belgium. What are the commitments of the convention for the patients? So between 0 and 3 years, they have to come 3 to 4 times a year, and between 3 and 18, 2 times a year, and over 18, once a year. It doesn't mean that they are not entitled to come more often, but they have to come at least this number of times, otherwise they are not included in the convention. What are the commitments of the convention for the multidisciplinary team? They have to attend the clinics, they have to attend the weekly meetings, so we have to have a weekly meeting with all the members of the team about the spina bifida patients who come that week. They have to be the go-between for the care in the home situation, and that's a very important thing. They do not need to do home visits, but they have to have contact by phone or by writing with the home situation. The coordination of care with input of the individual and the family, so they have to know more about the situation at home, and they have to gain more and more knowledge on spina bifida. In the beginning it takes time, because the members of the team, some of them were already familiar with spina bifida, but others not. At my retirement, I was very happy 2 years ago to find the publication of the University of Boston saying that the role of the nurse coordinator in spina bifida clinics was most important. So up to now, we always thought that it should be a doctor who is the coordinator. I think in our team now, the main coordinator is the nurse who came in 2005 and who takes over the youngsters when they go to the adult clinic. And you have to have a good contact with all the medical person playing in the team, the doctors. But as the pediatrician is changing to adult doctor, and all the people are coming in adult clinics, they want to have a person they know and who can arrange things for them. And I see that our nurse, who is now active since 8 years, is very capable to do this kind of job. She has to have a good relationship with the doctors, but I think a nurse is a better person to do the coordinating than a doctor. What's the added value of teamwork? We saw for all this time between 78 and 13 that it's so important to listen to parents and patients and to answer their questions. And a nurse has time when the patient comes in and has to go take off the clothes, go for controlling the weight and so on. They have time to talk to them. And I think that this is very, very important as well for the patients and the parents as for the doctors. What's another added value for multidisciplinary clinics is more attention to early transition and for appropriate education, for better job creation. So talking with them and seeing what they are able to do and what they want to do is important. And then we already talked about prevention of the secondary disability, and there was a very good article recently about what is secondary disability. Is disability you can prevent if you act in time. For instance, like obesity, you can implement exercise programs and reduce caloric intake early in life, but also participation in school and in life. It's important to educate the parents in time. And also the last point on dependence, it's parental overprotection. I think that's the main problem in a lot of our patients, and we have to help the family and the child for training to be independent early in life. And we see in Africa that a lot of those youngsters who attain the adolescence have been fighting in the early life already, and most of them are more independent than our children in Europe. But we see this boy there, we saw them for the first time, and when he came, he was able to walk, but he couldn't walk because he didn't have flat feet. So we see that it's necessary to have team members to detect early and to have treatment early in life when it's possible. The wound, this girl there showed me the wound at school, and I saw her 3 months later and the wound had healed. You couldn't see anything. I thought she showed the wrong foot. I say, show me your other foot. And then she said, no, my grandmother treated it with honey. And since that time we have been treating a lot of wounds, also because of the incontinence. We see a lot of children who do not have been treated for incontinence when they are 2 or 3 or 4, and they don't have pampers like we have in Europe, so they use a lot of plastic, and in the plastic they don't have dry cotton, so often they have wounds and parents do not talk about it. You only see it when you examine the child and take off the clothes. You smell it, and then you see the wounds, and we are treating these wounds all with honey, and it gives very well. The secondary conditions of ulcer care, spontaneous fracture, growth and puberty, obesity, latex allergy. I don't know if you have problems with the latex allergy here. We did a test and 1 in 3 had positive latex allergy when we did the test, but they didn't know it. Some of them knew it, but most of them didn't know it. But since that time, it's long ago, we did prevention of latex allergy, and we saw in a lot of these positive patients that the latex allergy could disappear, diminish, and so we only found a few ones who stayed, because it's important to know that if they have latex allergy, they cannot eat nuts, and some are allergic for bananas and so on. When they grow up, the focus of counseling will change when growing up from advice to parents to advice to youngsters. This is the theme for the adults. It's the same neurosurgeon, but this is in internal medicine instead of a pediatrician. And this is the urologist for adults. So the doctors will change, but the team will stay the same. I think a lot of patients are very anxious to be in follow-up in a new clinic with a new doctor who doesn't know. And that's why the nurse, the coordinating nurse, plays an important role. Because if a doctor has to start asking, when did you start having problems? Because we had it in our country, they had to go for controls for special appliances and so on. And the new doctor always said, and when did start your problem? And then my parents were very angry. They say they know that they have spina bifida. No, they didn't know that they had spina bifida. It could be an accident or other things. So every doctor has to ask the same questions, and parents do not like it. So it's important that you have a good follow-up also in neurosurgery. The key to maximizing developmental outcome is to emphasize on strengths and to build on them in children and in young adults, in adults too. Think abilities and not disabilities, and focus on the strengths rather than the deficits. And to put this all together in practice, professionals have to work together in a team. It's very important. This lady has spina bifida, and she was head of the National Health System in England, and they asked her when she retired or changed job, what's the key ingredient to respect for the rights of people living with long-term impairment? And she said the answer is shockingly simple, it's communication. Professionals have to see beyond their case notes, see beyond the impairment, recognize disabled people as carers, parents, employers, and potential lottery winners. I think it's a good way to stay. Then we come back to Our Lady, Amina, and the whole thing is how to promote good health to prevent problems and how to improve quality of life at different ages. And so we come to the project of the International Federation, where in several projects in East Africa, we try to communicate what we have learned in our own setting in Europe.